Hello and welcome to Alcohol Matters in General Practice. My name is Dr. Rachel Phillips. I'm a GP in Edinburgh and I've made this presentation with RCGP Scotland and SHAP. SHAP stands for Scottish Health Action on Alcohol Problems. It's a partnership of medical royal colleges and faculties in Scotland, set up in 2006 by doctors from different specialties who were increasingly concerned about the number of problems they were seeing in their clinics caused by alcohol, wanting to take action upstream of their patients and influence national policy. When I mention alcohol harms in patients, I wonder who comes to your mind. I remember distinctly a lady in my first GPST1 job a few weeks in who confided in me that she was drinking up to 3 bottles of wine a night in the context of significant trauma in her childhood. I hadn't a clue what to do next, and I spoke to the senior GP supervising me, who said nothing's going to improve here until she stops drinking. Like you guys in training, I didn't struggle to have empathy for my patient. I just really didn't know how to help her. And what she needed was someone who was informed, who knew where to signpost her to, who understood the physiology and psychology of addiction and was able to give safe, practical advice and help build her agency and hope for the bumpy road ahead. 10 years on, I'm still seeing a lot of patients coming to harm from alcohol, and I'm still learning how best to help them. But the very patients who used to overwhelm me are becoming increasingly a major source of job satisfaction for me, and I hope that the same could be true for you too. I started this with a rather extreme example, but this talk will touch on the wide spectrum of alcohol harms that we see in everyday practice. Let's start with some facts to understand our Scottish context. What percentage of Scots drink more than 14 units a week? Well, whether or not you depend on self-reporting questionnaires or look at the overall alcohol consumption in the population, the result is around 20%. So 1 in 5 Scottish folk are drinking to what we consider harmful levels. And what percentage are teetotal? Well, this might surprise you. It's actually 19%, up from 11% in 2003. And what's interesting is that although most alcohol here in Scotland is drunk by folk in the middle and upper socioeconomic classes, those in deprived communities are drinking at more extremes. That's where you'll see much more harmful alcohol consumption, but also that's where you're more likely to find people who are actually teetotal. What kind of death does alcohol cause? When we're thinking about alcohol harms, obviously mortality is going to be the bottom line. We can consider this in terms of alcohol specific and alcohol contributed deaths. Alcohol specific deaths include deaths from alcohol poisoning, alcohol liver disease, alcohol dependence syndrome, whereas alcohol contributes to deaths from a much greater variety of sources: road deaths, assaults, falls, suicide, cardiovascular and cancer. Alcohol-specific deaths are easier to be coded and therefore more quantifiable, and so they actually act as a helpful proxy for the rates of all death caused by alcohol and indeed all alcohol harms. When considering the harms of alcohol, it's also worth noting that it really contributes to premature deaths, either by affecting young adults through assault, accident and mental health issues, or those in middle age through liver disease. Let's zoom in on Scotland specifically. So in 2023, there were 1,277 alcohol-specific deaths, the highest number since 2008 and a 25% increase since 2019. 836 of those deaths were men and 440 were women, so we're looking at a ratio of 2 to 1 across the gender divide. Another way to think about this is that there are at least 25 deaths specifically caused by alcohol per week in Scotland, and this roughly doubles to about 50 deaths a week if we include all the deaths that alcohol has contributed to. As I said before, alcohol-specific deaths can be known with higher certainty because of the way we code our death certificates, but it is a helpful proxy for all the other deaths contributed to by alcohol. And who are dying? Well, alcohol-specific deaths in the most deprived areas were 4.3 times more than those in the least deprived in that 2023 data. The good news is that that is actually an improvement, because you can see not that long ago we were looking at 8.7-fold difference. There's no doubt that alcohol majorly contributes to health inequality, and that isn't just because of the polarity in consumption that I mentioned earlier, but it's multifactorial, as poverty, smoking, comorbidities, adverse events in childhood all compound the harm caused by alcohol. A report published by the Health Foundation in 2023 on the state of health and health inequalities in Scotland points to the fact that young and middle-aged men in our poorest communities are most at risk of poor health, with suicide, alcohol and drugs being the leading cause of death for men aged 15 to 44, what they call the deaths of despair. And it's not just deaths. If we look at data from the public health hospital admission records, we can see that there were over 30,000 alcohol-related hospital admissions in 22 to 23. The majority of this was to acute hospitals, so not just psychiatry. And you can see that there's still an overwhelming majority of these admissions were men and from deprived areas. Basically, someone in Scotland is admitted every 15 minutes to hospital due to an alcohol-related reason. Well, hopefully I've convinced you that Scotland has a significant problem with alcohol harms, but it's time for some good news. What measure reduced alcohol consumption in Scotland by 3% over the last 8 years? Well, I'm hoping you might have heard of minimum unit pricing. It was actually a world national first here in Scotland, where in 2018, 6 years after initial legislation, the minimum price for a unit of alcohol was set at 50p, and this was updated in 2024 to 65p. SHAP played an important role in the stages of getting the law passed, fighting the alcohol industry's legal challenges, and then getting it updated last year. It's led to a 3% reduction in alcohol consumption, and the WHO recommends price and taxation as the #1 way of reducing alcohol harm. What is a risk-free number of units of alcohol to consume in a day? Yes, you guessed it. It's none. There's actually no safe level of alcohol consumption. The Chief Medical Officer changed the guidance in 2016 so that the lower amounts of alcohol which we used to consider no risk are now called lower risk. And the 2016 Global Burden of Disease study published in The Lancet concluded that they found that the risk of all-cause mortality and of cancers specifically rises with increasing levels of alcohol consumption, and the level of consumption that minimises health loss is 0. There's recent evidence that shows that the risks of red wine on cardiovascular health actually outweigh the benefits. Small amounts can interfere with prescription meds, and there is definitely no safe amount in pregnancy. So what is a unit again? Well, if we're going to expect our patients to know how many units they drink a week, we better remind ourselves what is a unit of alcohol. And I've taken this from a really helpful e-module available on Turas just now as of 2025, which helps remind us what a unit of alcohol is. It's essentially 8 grams of pure ethanol, and it's what a normal healthy adult would take an hour to process. And you can work out how many units are in your drink by taking the strength and multiplying it by the volume and then dividing it by 1,000. So if I use a relatable example to us all, a bottle of wine on average 12% would be 750 mils, and that gives you about 9 units. I think it's helpful to just remember a couple of key examples. So for a large strong pint of beer or lager, I remember 3 units, and for a large generous glass of wine, I remember 3 units. So if you look at this picture here, we're looking at about 3 units per glass there. We're looking at 9 units in that photo. There are loads of different tools that we have in GP to help patients count units and to be aware of it. I don't know which ones you've seen. One of my favourites is this one, which looks a bit like you're calculating someone's gestation period. And there's also scratch cards. It's just basically good to have a rough idea of what people are drinking and what we can consider harmful. So the UK medical officer reminds us that actually now for both men and women, lower risk is up to 14 units. And then you're looking at increasing harm for women up to 35, men up to 50. And then you're looking at really hazardous drinking above 50 for men and above 35 for women. I don't know about you, but I often have patients who say, well, I'm definitely not an alcoholic. I wouldn't say I'm dependent, doc. And I've always thought to myself, well, would I say you're dependent? So a good reminder from the NICE guidelines: alcohol dependence is characterized by craving, tolerance, so the effect of alcohol becomes less over time, a preoccupation with alcohol when people are planning their days or weeks around alcohol, and continuing to drink despite being aware of harmful consequences. If someone Googles, am I dependent on alcohol, I can bet you anything they're going to be told, ask your GP. So that's why we need to have an understanding of what we would consider dependence. And also, if we're in doubt, we should ask how much people are drinking. So you've probably heard of the audit tool. Something I use, which I find just quicker and easier to kind of insert in a more natural conversation, is something I learned as a medical student, the CAGE questionnaire. You've probably heard of this. The C stands for, are you concerned at all about how much you're drinking? A, do you get angry if people ask you about your drinking? G, do you feel guilty at all about what you're drinking? And E, do you ever need an eye opener? And I try to get those questions in a kind of natural way in a conversation rather than a tick box. An alcohol brief intervention is an evidence-based structured conversation between clinician and patient, and it basically draws on techniques from motivational interviewing, which you will all recognise. I don't know if you're aware that motivational interviewing actually came from Scottish-based psychologists working in addiction, Miller and Rolnick, and probably the principles of asking permission to talk about the topic, asking open-ended, non-judgmental questions, generating chat around the subject by getting patients to work out where they feel on a scale, and also trying to generate what we call change talk from the patient, getting them to identify incentives. All those things will be something you're hopefully familiar from med school. I did think, however, it was worth maybe putting in a few practical tips from my own experience and from also talking to some nurses who work in addiction. There's been some qualitative research done by SHAP with folk in recovery, which revealed that an over-focus on counting units can actually be experienced as rather impersonal. So although I'm reminding you what a unit of alcohol is and helping you be literate in alcohol units so that we can be objective and accurate with our patients, I'm also recommending not to over-focus on counting units, but to try and make it more of a natural conversation. One top tip that I've picked up is to ask something like, what's your tipple? And when the patient replies with what they like to drink, I might say, So your tipple is whiskey, and would you get through 2 bottles a week? And that allows the patient to feel that they won't shock you if they say, oh no, only a bottle. And that's because it's really important that we just don't look shocked or embarrassed, but remain very matter of fact in our questioning. Don't look horrified when we get the answer, and I do wonder what I must have looked like when that first lady in GPST1 confided in me. And also not actually to get too emotional about it either, but just to remain very calm and very pragmatic. I think staying factual is really helpful for both us and for the patient. I remember, for example, being in a dilemma when a senior civil servant patient who had opened up to me in the past about their alcohol use. Another tip that I've picked up from an expert in addiction is what to do when a patient attends drunk. I don't know about you, but I've had this quite a few times, patients coming inebriated, patients who I already know are struggling with alcohol. And I think it's really helpful just to not waste your time engaging when they're drunk. They're unlikely to remember your conversation, and it will end up just be really frustrating to you. So I think kindly and in private explain that you would like to see them again when sober, and offer them an appointment that suits. And morning appointments are usually better for folk with alcohol problems because they're less likely to be drunk early in the morning, and you could see them before they start drinking, whereas afternoon slots often work better for those dependent on drugs. So if we start with the premise that about 1 in 5 of our patients are drinking at hazardous levels, and you look back on your last couple of weeks of practice, which patients do you think were drinking too much? Some will be a lot more obvious than others. I'm going to look at 3 familiar scenarios that I've taken from my own practice, and hopefully you'll be able to relate to them. We're going to consider Mr. Beattie, Sonia, and Mrs. Anderson. So let's start with the obvious. This, of course, is not Mr. Beattie, it's Mr. Beattie's sister. And you're in a very busy on-call duty day, and you get a distraught phone call from Mr. Beattie's sister, who's at her wit's end, wanting an urgent home visit for her brother. Mr. Beattie, a man in his 60s living alone, started drinking at home by himself during lockdown, hasn't had any contact with you and has no desire to have contact with you, wants to be left alone, thank you very much, doesn't feel there's any issue, and yet his sister is at her wit's end. I'm sure this will sound familiar to you. We know that someone like Mr. Beattie should probably have a FIB-4 score, and I'm sure you're aware now that we no longer rely on liver function tests to guide whether or not someone could be at risk of cirrhosis and requiring a FibroScan. We know now that liver function tests actually are not a good marker of cirrhosis, and so if you've got a woman drinking over 35 units and a man drinking more than 50 units of alcohol a week, it's probably a good idea to organise a FIB-4 score, and if that's high, they'll need a FibroScan. We also know that someone like Mr. Beattie should be on regular thiamine to reduce the chances of brain damage from thiamine deficiency. But we're probably also thinking, how on earth would we get someone like Mr. Beattie to comply with a tablet 3 times a day? We know that he's probably going to need to be under gastroenterology and have assessment for varices and be on some sort of prevention to reduce his risk of upper GI bleeding. Clearly his family needs support. And we know that Mr. Beattie would actually be at risk of withdrawal, which can include fatal seizures if he were to stop abruptly. And so it's really important that we help guide a slow reduction. But have we considered ARBD, alcohol-related brain damage? This is not a term I was aware of until a couple of years ago, and it's basically an umbrella term for all the different ways that alcohol can damage the brain, be it through affecting your vascular supply, causing traumatic brain injury, be it through direct toxic effects on the brain cells or through thiamine deficiency. ARBD is quoted at around 1.5% of the population and occurring in about 30% of heavy drinkers, but those figures are actually really debatable and probably underrepresent, as they are taken from post-mortem findings in the 1990s. Given how much we're consulted these days about things like, for example, autism, which is apparently meant to be 1.1% prevalence, although again that's also disputable. This is actually a huge problem that we're probably not recognising as much as we could be. I wonder if you start to think of patients that this applies to, would it change at all how you might approach them? What do we see in ARBD cases? Well, the classic cases are like Mr. Beattie, over 50 men living sort of chaotic, neglectful lives. But in fact, we are seeing increasing numbers of younger patients and also women who may mask difficulties for longer due to better social skills and social networks. And so although Mr. Beattie is the classic ARBD patient, we've got to bear it in mind for other folk as well. And we're seeing younger people who've started drinking younger and heavy and have been drinking heavily come through with ARBD much younger than you would think. Recently, I saw a patient who had ARBD coded in her notes, and she came to see me, and I was really confused because she was making total sense living an independent life, and there was nothing about our interaction that made me think she had some sort of brain damage. And that's because she was actually an example of someone who had made a great recovery by becoming sober. She had gone into an inpatient rehab program, got away from the difficult relationship which had fueled her drinking, and within a few months had gone from someone that was so confused the inpatient team were considering applying for guardianship for, to someone who could then actually live independently. And we know that actually some people can recover, and it's impossible to know who's going to recover. And a lot of the recovery happens in the first few months when you become sober, but can continue for a few years. And I think that actually understanding that people can recover and spreading that message is really important. How does this help Mr. Beattie? Well, Mr. Beattie might not be one of these patients who manages to become sober and to recover their brain function. But at least if we can understand what's happening a bit in his brain, we might be able to make more realistic plans for him and not overestimate his ability to look after himself, whilst balancing it with respecting his agency. You know, the truth is that people like Mr. Beattie, I think, are falling through the cracks. There really isn't great community support for folk with ARBD. Here in Edinburgh, for example, GPs cannot refer to an inpatient ARBD unit. That has to come from hospital. But if we code ARBD and our patient ends up being admitted to hospital for other reasons, they may then end up being referred onwards. Some social work departments are increasingly engaging with ARBD, and I suppose if we don't start recognising it and counting it, then we won't have a platform to advocate for more support. And what about Mr. Beattie's sister? Well, it might be helpful to be explicit with her about the effect that alcohol has had on her brother's brain. That might help her cope with his behaviour and help her understand that he's not being difficult or uncaring towards her, but actually that his brain has been affected by alcohol. And it might help us think about letting her know about things like Scottish families affected by alcohol and drugs, or Al-Anon. I don't know if you've heard of Al-Anon. It's sort of the AA version for the loved ones of addicts. Of course, our patients may also be the family and friends of those drinking too much. So, you know, in likelihood, Mr. Beattie's sister is our patient too. Some of you may be familiar with Brassic. It's a comedy series set in Northern England, which is now on Netflix. One of the series creators lost his own father due to alcoholism while he was writing the season. And we have permission from the production company to play a vignette from Series 4, Episode 7, which captures so many of the mixed emotions and tenderness and challenges that many of us or our patients might relate to of loving someone who is an addict. It can be really hard to stay mindful of this in the middle of busy clinical days. This might prove a little bit too close to the bone for some of you with personal experiences of alcohol dependence in your family, so you are welcome to skip the next 4 minutes if you want to. That's the end of part 1. Grab a cuppa, take a break, see you back for part 2. Hello and welcome back to part 2, Alcohol Matters in General Practice. We were saying that 1 in 5 of our patients are drinking to hazardous levels. And the obvious ones are those who have alcohol-related brain damage and their family at their wits' end. But there are much less obvious patients. So here is Sonia. You might recognise her. She's a lady in her 40s. She's experiencing tingling in both hands and she's very worried that something is wrong with her nerves. When you take a full history, it actually comes out that she's drinking a lot of alcohol and is feeling very anxious. Sonia is not going to bring alcohol into this consult if you don't. Maybe she's embarrassed. Maybe she genuinely hasn't made the link between alcohol and her symptoms. So our job is to consider it and to ask about it, to make explicit links to someone's symptoms and to educate about the risks of alcohol. So for example, I often tell patients that alcohol is a major depressant on the brain, and although it makes us feel good in the short run, it can actually be driving down our mood and increasing our anxiety without us realising. We also need to help patients avoid harm from withdrawal and give them practical, safe advice about cutting down slowly, signpost to the right support, and of course build therapeutic rapport. So is Sonia at risk of withdrawal? Well, it can actually be hard to work this out. How do you know when to advise someone that they should not stop drinking suddenly? Well, I'm finding this booklet from SHAP increasingly helpful, and we have a text link to it in our practice, so you can text it to the patient without having to print it out. I usually go straight to this page of the booklet and read it together with the patient. If they're drinking over 15 units of alcohol a day, if they've had withdrawal symptoms in the past, and if they're needing alcohol when they wake up to relieve shakes or sweats, all those could be signs that they are at risk of withdrawal. And we know that withdrawal can be really serious. It can include fatal seizures. The booklet goes on to give patients an example of how they might tackle slowly cutting down their alcohol over a few weeks. One practical tip might be to start with what the patient thinks is realistic. Could they switch, for example, to a lower strength, or start by pouring a glass away from a bottle before drinking the bottle? When I was a GP trainee, I had a number of patients who'd had withdrawal symptoms in the past, even one with a seizure, who put me under pressure to prescribe diazepam for them in the community to cover their withdrawal symptoms and make it easier for them to become sober. And I found it really difficult to say no. It felt that I was being unhelpful and obstructing their intention to get sober. But now that I understand that it's just not safe for us to prescribe in the community, and also that it's genuinely not effective, that folk really need to get plugged into specialist support services and have a build-up of rapport and relationship prior to detoxing in the community, or in fact might need an inpatient one depending on their risks, and then also have follow-up support in order to make that detox likely to succeed. now that I've understood that, it's much easier for me to have a very firm boundary with patients and explain that it's not safe for me to prescribe, it's not effective for me, they need to plug into the services, and even though they want to do something immediately because they're feeling so desperate, it wouldn't be good practice to. And it's very clear now that GPs should not be prescribing for withdrawal in the community. It isn't our role and it isn't safe. And I think once you've got that firm boundary and you understand that, it makes the consults much easier. And I guess the other thing in the room is what's driving Sonia's drinking. And asking isn't going to hurt. I think that a lot of us might fear sort of opening a can of worms that we don't know how to deal with, or insulting or offending a patient. But actually there's good evidence to show that people who've gone through something traumatic are not going to be re-traumatized just because you ask about it. In fact, it's more helpful to be curious about it and to recognize their experience. And of course, not everyone is drinking due to trauma, but asking won't hurt. Sometimes we don't ask because we're aware of this catch-22, that someone is drinking because they've got psychological pain, but they can't actually access counselling when they're still drinking. And although that is true of some services, it's not completely true. So for example, ELCA here in Lothian does offer counselling to folk who are still drinking. Our job is really to understand the physiology and the psychology of addiction. And I think understanding how alcohol comes to dominate the dopamine reward pathways in the brain of someone who has become addicted helps us understand why they start to prioritise above it all else, and at great cost everything else that they actually do care about. And it allows us to see addiction in terms of the scientific process happening in their brain, rather than some sort of character flaw or a weakness which compounds the shame and stigma that a lot of folk feel. It's useful to be able to explain to someone that when they come off alcohol in the early days of recovery, they will actually find it hard to find pleasure elsewhere. And that's because for so long alcohol has totally dominated their dopamine reward pathway and nothing else will compare. And it will take some time before they can enjoy more simple pleasures like going to the cinema or having a coffee. And I think it's quite helpful for them to know about that in advance, because those early days of recovery can be, a really hard slog. And having faith that things will become pleasurable again is helpful and motivating, because a lot of folk actually realise how much happier they are when they can start to get pleasure from elsewhere, not just from alcohol. For patients, it's worth that they know this so they can keep going through the motions, get distracted, keep busy in the faith that it will become more satisfying. There's also the issue of craving, which is complex, not fully understand. It's a condition response that involves stress, triggers, dopamine pathway. The opposite of addiction is connection, hence the importance of building a relationship with the patient, but also even more so of helping them build relationships with peer support and mutual aid. And this is again something I really wasn't aware of when I started GP training, just how sophisticated and extensive the recovery community is. So here in Edinburgh, there's an activity organised every single day of the year, including Christmas Day, for people in recovery. And there's so many different types of recovery communities out there. It's not just AA, which might not be for everybody. If secondary care provides medication, not us, for withdrawal, and if the third sector supplies the kind of ongoing psychological support, then I wouldn't blame you for asking, what is our role as GPs in recovery? Well, I'd put it back to recovery capital, assertive linkage, and holding the hope. The importance of connection for recovery is based on solid evidence, and connection helps build recovery capital. Recovery capital means our internal and external resources that we can draw on. So as GPs, we can be part of a patient's recovery capital, part of their external resources that they can draw on, but we can also help them understand their need to build other recovery resources other than us. Someone may have developed a relationship with alcohol for good reason, to bring them comfort to cope with emotional or physical pain, and they can't be expected to just stop that coping mechanism without finding alternative sources of support, relief and pleasure. In other words, addiction generally emerges as a way to manage something. It's serving a function, and that can actually be quite a refreshing way to look at it with our patients. Number 2, this assertive linkage. Assertive linkage is about consistently signposting to the right places for support and planting that seed early that mutual aid and recovery communities are essential. Even though most patients might be initially very reluctant to consider them, it is, important to sort of start that conversation. In a climate of GP bashing, it can be really easy to forget the power and potential that we have. So I'm just going to pause and reinforce those points, because you are not a glorified phone handler. People will hear some of what you tell them, and most of all, they're going to remember how you made them feel. And so actually we have a role as a GP that is easy for us to forget. So how can we help aid recovery? Explaining the concept of recovery capital and encouraging people to increase their own recovery capital. Assertively linking to the right sources of support. And I don't just mean signposting, I mean saying something with conviction, like evidence shows that you're much more likely to succeed if you can engage with other folk in similar boats, or I know you probably don't fancy it, but it is true that if you could engage with peer support, that's probably going to do you more good than any drug. And then holding the hope for the patient. They may feel hopeless, which is part of the effect of alcohol on them. And so we need to remain hopeful for them. So what do you know about mutual aid and peer support in your area? We've got apps, and apps are quite helpful for folk who are too shy to get out and about or to link with people local, because there are apps where you can actually interact with folk all over the country. There's the classic Alcoholics Anonymous, and there are so many AAs around the country, there's bound to be one near you, and I think it's worth you knowing where your local meetings are and what the times are. AA isn't for everyone, and there are other things like smart groups, and there are websites like these ones all listed, which focus on recovery and recovery stories. And I think for some folks, seeing realistic and relatable examples can help. So we've got the obvious, we've got the less obvious, and then we've got the patients who it's not obvious to them or to us that alcohol is at all part of the picture. So Mrs. Anderson, she comes to talk to you because she wants HRT. And I'm sure this sounds familiar to you all. I'm getting lots of HRT consults a week. Mrs. Anderson is worried because she knows she's got a slightly high blood pressure, and one of her aunts had breast cancer. But she's still really curious to try HRT and wants to discuss it with you. She's not thinking that actually alcohol causes 1 in 10 cases of breast cancer. And this is a video that I'm going to play you with consent from the makers.
In 1988, alcohol was added to the list of Group 1 carcinogens by the International Agency for Research on Cancer, alongside tobacco, asbestos, radiation, and viral infections such as HIV and HPV. This classification, put simply, means that alcohol causes cancer, yet public awareness of this remains remarkably low. Drinking alcohol is known to cause at least 7 types of cancer: mouth, upper throat, voice box, food pipe, breast, liver and bowel cancer, and there is increasing evidence that it may be linked to pancreatic cancer. Each year in the UK, alcohol causes as many cancer deaths as deaths from alcohol-related liver disease. But how does alcohol cause cancer? How many cases and deaths does it cause? What are the levels of risk? And what can be done to reduce this harm? There are a number of ways in which alcohol can cause these types of cancer, and all types of alcoholic drinks, whether beer, wine, spirits or cider, can cause cancer, as it is the ethanol in the product that causes it.
There's at least 3 potential mechanisms for how alcohol causes cancer from what we know so far, although there may well be others. The first is we do know that acetaldehyde, that metabolite of ethanol that we metabolize into our systems, damages cells. And what it does is it gets into our DNA, and that means 2 things. First of all, there's cell damage in the first place, but secondly, it can also affect how cells repair themselves. That's the first mechanism. The second one we think is about hormones. So we know that alcohol can change the level of hormones in our body, particularly estrogen and insulin. Hormones send signals around the body, and when those levels are elevated, we know that cells can divide more rapidly. And when those cells divide more rapidly, there's a possibility that an error will be made in that replication, and that is a link to cancer. And then finally, we know in particularly for the cells that line our mouth and our throat, the damage that alcohol does to those makes them more vulnerable. And that means when we absorb different things, whether it's alcohol or maybe if we're smoking, that those cells are more vulnerable to absorb those toxic compounds. And again, there's a link to cancer there.
The more you drink, the higher your risk of cancer, which is why the World Health Organization states that there is no safe level of alcohol consumption. This doesn't mean that you will definitely develop cancer if you drink, but your risk will decrease if you reduce or stop drinking alcohol. And it isn't just people drinking heavily that are at risk. In fact, across Europe, half of all alcohol-related cancer cases are caused by light and moderate alcohol consumption. Yet the number of cases caused by alcohol does vary substantially across each of the 7 cancer types. Breast cancer is the most common cancer in the UK, and alcohol causes a significant number of cases, between 8 to 10%, which is around 4,500 cases every year. 22% of voice box cancers, 34% of mouth cancers, and 38% of upper throat cancers are caused by alcohol, likely between 3 to 5,000 cases each year. And for food pipe, liver and bowel cancers, 13, 7 and 6% are caused by alcohol respectively. Of course, it's important to consider how risk changes with different levels of drinking.
Another example might be to take, for example, a typical female who is drinking no alcohol. What's her risk of breast cancer? Well, we know that can be around 11%, and not accounting for the range of other risk factors she might have. And then if she drinks above the recommended weekly limit, so say she's drinking 14 to 35 units a week, that risk increases to about 17%.
That's a very good video, and I can recommend watching it all, but let's pause at that point that the professor has raised. Breast cancer increases your risk from 11% to 17% if you're drinking more than 14 units a week. So if we return to Mrs. Anderson's presenting complaint, she's worried about her risk of breast cancer if she takes HRT. Well, if you're anything like me, I have to keep looking this up, and it does seem to keep changing. But at the moment, the NHS is saying that HRT can slightly increase your risk of breast cancer. There are around 5 extra cases of breast cancer in every 1,000 women who take combined HRT for 5 years. And the risk increases the longer you take it and the older you are, and it falls again when you stop taking it. So if we try to compare that with the risk of cancer, it gets very messy, because on the face of it, it might look like we're contrasting a 0.5% increase in absolute risk of breast cancer with HRT versus a 6% increase in absolute risk from alcohol. But it's more complicated than that, because the risks of HRT are reported over specific timeframes and not a lifetime risk. And the risk associated with HRT spikes during use and then fades after stopping. whereas alcohol's effect is usually reported as a lifetime risk and it accumulates steadily. HRT is typically used around menopause when baseline breast cancer risk is already rising. So you can't totally compare the two, but you can hopefully get the point that I'm making, because HRT, breast cancer risks, that's something constantly on our minds in the media, but are we really thinking about alcohol? And of course, combining both alcohol and HRT can amplify the risk. So if you think about your last week in practice and which patients were coming to harm from alcohol, you've got the Mr. Beatties, the Sonias, the Mrs. Andersons, but who else might be worth considering? What about people presenting with indigestion and reflux, folks struggling to sleep, folks complaining of tummy pain, people attending for blood pressure reviews, and those at risk of cardiovascular problems, and folks struggling with their mental health? Of course, the other person who's been in all your consults over the last week has been yourself. And it would be really remiss of me not to bring this up, because the sort of people who go into medical school, the environment of medical school, and our busy and stressful work life all put us at risk of alcohol harms ourselves. And with permission from Hazel Martin, I'm going to show you a clip from the documentary that she made called Binge Drinking in Me, which was a panorama documentary available on BBC iPlayer. Hazel was a middle-class, successful, professional mum. She worked as a journalist. She had a small child. She went to her GP complaining of tiredness, and a routine screen surprised her and her doctor with deranged liver function tests. That led to a FIB4 and eventually a FibroScan, and she was told that her liver was borderline cirrhotic, which led to her investigating as a journalist how on earth this could have happened, not something that she expected for herself. I've taken this excerpt with her permission from her documentary. None of us are immune to the harms of alcohol, or even to stigma, to feeling it towards ourselves or towards our patients. SHAP did this research recently with a focus group of folk in recovery, and it makes pretty uncomfortable reading for us GPs. In it, they talk about how feeling stigma from GPs and from A&E staff as people who had brought their problems upon themselves, who were time wasters, who were blocking beds, actually made it harder for them to recover from their alcohol addiction, and also prevented them from accessing healthcare for other reasons, even if they were nothing to do with alcohol. Stigma is about how patients think of themselves and how they perceive we think about them, all gleaned from how we talk and listen in consults. So we need to start by being honest about how we perceive the control people have over the choices they make, and therefore the blame that we might actually be feeling towards our patients. We also need to think about whether we actually can maintain hope for them, and remember the power of recognizing the self-shame that is usually in the room. Recently, rather than asking a patient about the unit of alcohol he drinks or his plans to reduce, I simply asked him about how he felt about his drinking and what he thought lay behind it. And he seemed genuinely surprised to be met with curiosity. And it did actually feel a wee bit transformational for both of us. Although I continue to watch him struggle with his relationship to alcohol, those 7 minutes of our first encounter felt like a really worthwhile use of time, and actually much less frustrating for me as well, rather than trying to impose my agenda on him. And that's it. Thank you very much for listening. I hope this talk helps you recognise the harms of alcohol all around us a bit more, helps you explicitly acknowledge them and discuss them with your patients, gives you a few practical tips on how to help, and I hope that the very patients we often find overwhelming and frustrating will actually give you increasing job satisfaction. Thank you very much.